Right, so let's talk about the A to Z content for pulse oximetry. The contents that I've included in this PDF is the principles, parts of pulse oximetry, uh, isospastic point or the hemoglobin extinction curve, functional versus fractional saturation, types of pulse oximetry, oxygen hemoglobin dissociation curve, just an overview of this, various models of pulse oximetry, and the applications, all the applications, including the latest application, which is plethysmographic waveform analysis. And the last one being the most important, that is the limitations of pulse oximetry. You all must have seen that a pulse oximeter looks something like this. However, this is not the only version, but this is the most common form of pulse oximeter which we see, which is connected to the anesthesia monitor. It includes the following parts. Let's suppose this is the finger of the patient. On one side, there is an infrared diode whose wavelength is 940 nanometer, and the other diode is a red diode, it is 660 nanometer. This is an opaque cover, and on the opposite side of this diode, which will emit the infrared, and this will emit the red light, which will pass through the finger and will ultimately be detected by a photodetector. This is the basic structure or the parts of pulse oximeter. Apart from this, the probe, there is cable and a console which is connected to the machine. Obviously, the probe may be of various types, like reusable, disposable, self-adhesive, like a clip or like a band which can be worn on the wrist. So there can be different types of probes. This was about the parts. Let's move on to the principle. As we all know that pulse oximetry is known as a fifth vital sign. Apart from the heart rate, blood pressure, respiratory rate, temperature, the fifth vital sign is considered the pulse oximeter. It basically consists of two things. First, the principle consists of spectrophotometry and plethysmography. We'll deal with each of them one by one. First, we'll talk about what is spectrophotometry. This is that the light is absorbed or emitted over a certain wavelength spectrum by each compound. Now, this principle has two components, which is known as Beer-Lambert's law. Because it consists of two parts, one is Beer, one is Lambert's. Let's talk about each of them individually with a mnemonic. Beer law individually says that the intensity of the transmitted light is inversely proportional to the concentration. Now that means if a structure has lot of molecules, a concentration is too much, that means the light which is incident will not be able to pass through the structure, and the ultimate transmitted light will be very less. This is about the concentration and can be remembered by BC, that Beer law is related to the concentration. The more the concentration, the lower will be the intensity of the transmitted light. Then the other law is Lambert's law. Lambert's law, L for length, you can remember it by various mnemonics. L for L, that is length. You can consider length like a distance. Or L for lamba, lamba means dur. Dur is also like distance. So this is easy mnemonic for the same. It is related to the intensity of transmitted light is inversely proportional to the distance. So the more distance the light has to travel, the lesser will be the amount ultimately reaching, that is the transmitted light will be lesser. So more the distance, less will be the intensity. Now combining these two laws, there is an equation. You have to remember this equation for the pulse oximetry. So the intensity of the transmitted light is equal to the incident light intensity into the E, that is the base of natural logarithm, which is 2.718. Now E is to power minus D. D is for distance, that was the Lambert law, and C is the concentration, which was the Beer's law. And because in our human body this solute is actually nothing but hemoglobin, then A is the extinction coefficient, which is a constant. So for a given solute at a specified wavelength, because we are putting the finger under two types of wavelengths and the solute present is hemoglobin, that is why this is constant, which is extinction coefficient. And obviously because of hemoglobin, this A is known as hemoglobin extinction coefficient. After we move from this Beer-Lambert's law, let's talk about a mnemonic, that which wavelength absorbs which type of light. So mnemonic is this: oxygen. Oxyhemoglobin absorbs infrared light. Infrared, that is 940 nanometer of wavelength. So opposite will be deoxy, will absorb the red light, which is 660 nanometer. The other component of the spectrometry is the isosbestic point. What is that point? See, a point at which two substances absorb a certain wavelength to the same extent. That means there is a certain wavelength in between the 660 and 940. There's some wavelength in between which is absorbed by two substances equally, because we already know that 660 is absorbed mainly by the red light, the deoxyhemoglobin, and the 940 wavelength, which is the infrared light, is absorbed by the oxyhemoglobin. So in between there is some wavelength that doesn't matter how much deoxy or oxy is there, they both of them will absorb it to the same extent. Now what is that wavelength? This wavelength is 800 nanometer. You can see on this graph, this graph is the hemoglobin extinction curve with an extinction coefficient on the y-axis and wavelength on the x-axis. This point is the isospastic point, which says that oxyhemoglobin and the black line is the reduced or the deoxyhemoglobin. They are absorbing the light to the same extent, which is the isospastic point. If we talk about this point, this is 660, which is the red light. Now this red light, you can see this red line going till here, and the black line is going much above here. So this point, the black line has a higher extinction coefficient. That means black line or the deoxyhemoglobin absorbs more of the 660 light, which is the red light. And if we talk about this point, this is the 940 nanometer. Now this 940 nanometer, you can see the black line is below and the red line is above. So this red line above, that means higher extinction coefficient. So the oxyhemoglobin absorbs the 940 wavelength, which is nothing but the infrared light. So this curve shows why oxyhemoglobin is absorbing the infrared and why deoxy is absorbing the red light. And if you don't remember anything, just remember this mnemonic, which is oxygen. Oxyhemoglobin absorbs infrared light. This was about the isospecific point. Now the light source in the pulse oximeter, as we have already told, two LEDs, and the frequency is actually 0.621 kilohertz. And the photodetector, it detects the non-absorbed energy opposite to the finger that we are placing. This was all about the first principle, which was the spectrophotometry. Let's talk about the second thing, which is the plethysmography. Now, what does that says? It measures the changes in arterial blood volume during a cardiac cycle. Let me simplify it with this formula. You can see this equation that SpO2, this is calculated by the machine by dividing the red and the infrared light components. The components of individual will be AC by DC divided by again AC by DC. Now what is that AC and DC? You can see by this curve what is AC and DC. If we plot the light absorption with respect to time, you can see that obviously in a finger nail bed there will be some pulsatile component, there will be some non-pulsatile component. Now this pulsatile component, you can see this pulsatile component of the, that will be obviously the arterial blood. The absorption by this pulsatile arterial blood is known as AC, the alternating current. And whatever is the non-pulsatile thing, non-pulsatile may be the arterial blood during the diastolic phase, the venous and the capillary blood, and the rest of the tissue, that will be the DC or the direct current. Now obviously this same component will be calculated for the red and then for the infrared. Now when red and infrared component of AC and DC are divided, this will tell you the SpO2. How you may ask me, how does the machine calculates by dividing these two ratio, AC by DC of the red light and divided by the AC and DC of the infrared? It is because this ratio is compared with the stored ones in the microprocessor of the device. The machine already has a stored data for this, and that will compare it with the stored ones and give you a value of SpO2. Now this displayed SpO2 is actually a mean of measurements, 3 to 6 seconds. That means it is not a immediate value. You have to wait for some time. There is a lag time. When you apply the pulse oximetry, it takes a bit of time to get its value, and the data is updated every 0.5 to 1 seconds. This formula and this AC and DC component tells you about the plethysmography, the pulsatile divided by the non-pulsatile component for each of the light. There is one more curve, the same value, which is the R red divided by the infrared. We already know that the red is the deoxy component and the infrared is the oxy component by the mnemonic of oxygen. Now this ratio will decrease if either the red or the deoxy will decrease or the infrared, that is oxygen, will increase, which means that lesser the value, the lesser the R is to I value, more is the oxyhemoglobin content. That you can see on this curve, that if we put the red into red is to infrared ratio on the x-axis and SpO2 on the y, with 100% SpO2 the value is 0.4 only, which is much less. When we compare that, when the SpO2 has decreased to 85, now the value is 1. That means at a value of R is to I value of 1, the SpO2 is 85%. Similarly, if we keep on increasing the value of R and I 2, 3, 4, the SpO2 will keep on falling. So these are the important values. At Ri is value 1, 2, 3 and 3.4. These are the most important values for R is to I. This completes our uh, principle of pulse oximetry. Let's move on to what is the ambient light interference. This is like the noise or the unwanted thing. You must have seen that if we put a pulse oximeter, if it is loose and the OT light, suppose this is the OT light and it is projecting towards the pulse oximeter, now it will interfere and the pulse oximeter will keep on giving you alarms, fake alarms of different values. The curve waveform will be altered, the value will be, suppose the patient is perfectly fine, still it will show the value of 50 or 60. So it is not always about the patient getting bad because of a value of pulse oximeter. We are not treating monitors, we are treating patients. How is the pulse oximeter actually try to negligence the cut off the effect of ambient light is, suppose this is the pulse oximeter and there is only red light is on. This is the red light. It will sense the red light because there is the detector. It will sense the red light and it will also sense whatever is coming from the room. So it will sense the red and red plus the room light. Second time after, because of the frequency, it is alternating the lights. First it will show the red light, then it will show the infrared. Now when the infrared is on, obviously this infrared along with the room light, infrared plus the room light will be recorded, and then what will happen, both the LEDs are off. Now when both are off, only the room light is getting into the pulse oximeter, which will ultimately minus out the effect of the ambient light. The third thing, it will subtract from the first and second. So this is how it will negligible, there will be negligible effect of the ambient light. This is troubleshooting in the pulse oximeter nowadays. Let's talk about the types of saturation. One is the functional saturation and second is the fractional. Functional saturation, which is measured by the normal conventional pulse oximeters, which is the oxyhemoglobin divided by the total oxyhemoglobin plus reduced hemoglobin into 100. So this will be the functional SaO2. But suppose we want to check whether there's component of other hemoglobins like carboxyhemoglobin or methemoglobin. So the total hemoglobin will be the combination of oxygen, deoxyhemoglobin, carboxy and methemoglobin. So to calculate this, there are laboratory co-oximeters and this will be known as the fractional SaO2, which is regularly not done. Let's talk about then the types of pulse oximetry. This was the normal one, the transmission pulse oximeter, that there is some site, suppose this is the finger and there is a emitter which is the red and infrared light. It will pass through the finger and it will be detected by a photodetector. So the detector is opposite to the emitter. This is opposite, that is the transmission pulse oximetry. But now there are newer types of pulse oximetry, which is reflectance. The emitter and the photodetector, they are side by side. So if this is the pulse oximeter, this is the surface. On one side there is emitter, on one side there is photodetector. What does it do? It emits and it will get reflected and come to detector. Why at all there was a need for this reflectance? Why a simple transmittance pulse oximetry was not of no value? The advantage was that it is able to measure saturation in hypoperfusion and there are lesser motion artifacts and it can detect hypoxemia earlier compared to the ear or finger probes. So these are the advantages of this reflectance pulse oximetry. Most common site is the forehead. This is frequently asked, that the most common site for the reflectance pulse oximetry is the forehead. Now limitations is, suppose there is edema or there is a poor skin contact, or suppose it is directly placed over a pulsating superficial artery. Suppose this is the face and this is the temple part. Someone has placed it not only on this side but somewhere here. So this temporal artery pulsations may interfere with the readings. Then we come on to the oxyhemoglobin dissociation curve. This is in itself a big topic and various components inside, but you should remember that there is a relation between the partial pressure of oxygen and SpO2. This is very important because we can only measure SpO2 by the pulse oximeter, which is the amount of saturation of saturated hemoglobin by the oxygen, but we cannot calculate the PaO2 directly. So this curve tells you indirectly the value of PaO2 by the SpO2. Also, it will tell the shape of the curve. Oxyhemoglobin dissociation curve will tell you what is the status of the body for oxygen release. If the curve is shifted to the right side, that means the hemoglobin has lesser affinity to oxygen. If it is shifted to the left hand side, that means hemoglobin has higher affinity to oxygen. At the tissue level, obviously we require this thing to happen. So the factors which are in playing role to shift the curve to the right side should be present at the tissue level where the oxygen has to be delivered, but at the levels of lung, the oxygen has to have higher affinity. The hemoglobin has to have higher affinity for oxygen, and to shift the curve to the left hand side so that it binds the oxygen strongly and has to occur at the level of lung. So this is all you should remember about the shape, the shifting, and what is the relation between PaO2 and SpO2. Let's talk about this relation. That this P50 value is 25 to 27. You can see that this point corresponds to this 50. So at a partial pressure of 25 to 27, 50% of the hemoglobin will be saturated with oxygen, and after this point onwards it goes like this, and you can see at a partial pressure of 40 the saturation is 75. At a PaO2 of 60 there is 90%, 90 SpO2, and at a PaO2 75 there is 95, after which it becomes flattened out. That means doesn't matter how much PaO2 increases after this, the change in SpO2 is very less, or obviously it cannot increase more than 100%. Doesn't matter PaO2 value is 100, 200, 500, doesn't matter, because SpO2 is not going to change. So after a certain value, which is suppose 75 here, the change is very minimal, and you can't predict what is the exact PaO2 right now. You can't predict the oxygen toxicity by this. If you're giving too much oxygen to a normal patient, the SpO2 will keep on showing 100%. That doesn't mean that he's not getting excessive oxygen, and this excessive oxygen can lead to production of free radicals. So this is one of the disadvantage of pulse oximetry, that it cannot differentiate how much PaO2 is there. It doesn't matter how much oxygen you're delivering. And these are the factors which will shift the curve to the right, and these are the factors which will shift the curve to the left hand side. And the sigmoid curve we can see is because of the change in affinity, or the cooperative phenomenon. The cooperative phenomenon is that if hemoglobin, which has 4 binding sites, one of the oxygen binds to it, it will increase the affinity for the second oxygen and the third, and then further 4. This is the reason why it is a sigmoid shape. Let's move on from this curve on to the next thing, which is the signal strength. This signal strength is usually not present in all the pulse oximetry, but that is present in newer pulse oximetry like Catalyst, Datascope, in vivo, Ohmeda. What does this mean? That a full strength, which means there's a good perfusion, and there will be a waveform which have like this, and there will be a dichrotic notch. But if the strength is low, that means there's vasoconstriction or there's a low cardiac output state, and the pulse ox will look like this, which is a sine wave like waveform. And this signal strength value is also depicted from 0 to 100. So suppose the signal strength is 20, you know that there already the perfusion is very less, and even the waveform is not reliable. But when it is above 50%, that means the chances that the value which is shown on the monitor is much accurate. Then the BP curve and the pulse oximeter, we all know that we have to avoid it on the same side, because the BP curve will inflate and the supply, the arterial component is gonna remain the same, but the non-arterial, the venous supply and all that, they're gonna hamper. So this will have this, that's why we have to avoid it on the same side. But there are newer advances now. The Ohmeda oximeter, we can turn off the low pulse alarm, and in the Nellcore oximeter there is ECG synchronization. That means heart rate is normal and accurate despite the BP curve inflation. So these are the newer advances in the pulse oximeter, the Nellcore and the Ohmeda. They are very recent. Let's talk about the models now. We all know that there is fingertip model, there is wrist model, the handheld, or a tabletop, which we use in anesthesia monitors, the multi-parameter monitors. In the wrist one, it is worn like a watch, and sensor is on the finger. Short wire joins the two components, and the uses sleep study and will store a 24 hours data. You can see the representations of these probes. These are various finger probes. This is a ear clip assembled, and this is the assembled one, this is the disassembled one. And there's this flexi probe, usually in pediatric patients, where there's a band which you can push or you can pull so that this gets tightened up. This is the flexi probe. Let's move on to the before this ear oximeter. Suppose the reading is not coming. This is the ear and there is the ear lobe, and you have attached the pulse oximeter probe on it, and still the reading is not coming. It is better to rub the ear with the alcohol or using a small dab of nitroglycerin ointment, which will vasodilate or increase the perfusion, which will improve the pulse oximeter signal, because ultimately the signal strength has to be more so that the waveform is reliable. Regarding the applications or the uses, I would say that it is only the difference in place you are using pulse oximeter. Otherwise, it is going to do the same thing. It is going to give you a value of SpO2 and a waveform. So these are the only two things that a pulse oximeter does. And now how you interpret it at different places is the application. You can use it in critical areas like the operation room, during the general anesthesia or the monitor anesthesia care, or a PAICU intensive care. You can use it in neonatal areas during the during the transport, the diagnostic labs like PFT exercise lab or sleep lab, home care patients, controlling the oxygen administration, avoiding hyperoxemia, monitoring peripheral circulation, determining systolic blood pressure because of the perfusion, locating arteries, monitoring the vascular volume and sympathetic tone, which is done by the plethysmographic waveform analysis. The waveform, which is like this, it will tell you about what is the sympathetic tone and the volume, the fluid responsiveness of the patient. and the intrapartum fetal monitoring. Specifically, I have mentioned in the neonatal area, obviously, it is about the diagnosis of CHD. The patient is cyanotic, and the patient is supposed TOF patient. So the saturation is not going to be like the normal patients. It will be much less, suppose 70 or 80% baseline, and the patient may be cyanotic. Then in the emergency department, you can diagnose COPD or asthma severity, pneumonia, bronchiolitis because of the desaturation component of them. And the target SpO2, this is the additional information that in COPD you don't have to target a SpO2 of 100. SpO2 of 92 to 94 is good enough because the hypercapnic drive of the COPD patients is already gone, and if you increase the SpO2 or the FiO2 given to the patient, even the hypoxic drive will fail and the patient will become it will get to hypoventilation state, so it will not breathe, and he'll further deteriorate because the CO2 will further increase or accumulate in the body. There is a mnemonic for the intraoperative desaturation DOPE. If the patient is desaturating in the OT, you have to think of disconnections, some obstruction, pneumothorax, pulmonary edema, pulmonary embolism, or some equipment problem. That is itself, this SpO2 probe has some issues. That was the equipment problems. The 12th component is the calculation of the volume by the plethysmographic waveform analysis. This is the latest advance and is quite confusing, and you need not go in detail of this, but let me at least introduce you this that for calculating the volume status of the fluid responsiveness in anesthesia, this is a very important task, because by looking at the patient you cannot see that the patient has dehydration or is overloaded. Usually it is very difficult to tell the fluid status. So to tackle this problem, there are certain invasive methods and there are certain non-invasive methods. In the invasive methods, very similar, the interpretation is almost very similar, because in the invasive we'll put a arterial cannulation, and when we put a arterial cannula, there will be a waveform again. Based on that waveform, the variations in the systolic pressure and the respiratory variations of the pulse pressure, you can see based on how much variations are there, you can predict the fluid responsiveness. In itself, it's a big topic. It's very similar to the waveform analysis of the arterial cannulation. People tried to find alternatives which are non-invasive. One of them is the pulse oximeter. Now in the pulse oximeter, this we have already talked about the perfusion index. So the pulsatile versus the non-pulsatile component, it will tell you the vasomotor tone or the vasoconstriction. So the lesser the perfusion index, that means vasoconstriction, higher the value of perfusion index, that is vasodilated state. The second thing will be plethysmography variability index, PVI. If it is more than 14%, that means there is predicted fluid responsiveness. And in the latest pulse oximeters, there is automatic measurement of this change in PI. How is it calculated? It is calculated by dividing the difference of PL max by minus PL minimum by PL max into 100. This is the maximum amplitude of the plethysmographic waveform. PL minimum is the minimum amplitude of the plethysmographic waveform. So for example, this is the waveform. I'm not putting the diacritic notch, I'm just making a simple waveform. Suppose this is the waveform and it is moving like this. You must have seen on the monitor, it is not a straight line always. So this, you can see in this is the maximum amplitude and this is the minimum amplitude. So this PL max, and then this will be PL minimum. if you subtract them and then divide by PL max into 100, if this variability is more than 14%, that means the patient is fluid deficit and you can give him more fluid. Try to see this waveforms whenever the patient is suppose an emergency and is dehydrated, or patient is about to start on the vasopressors. Usually the waveform will have more of this up and down, up and down, up and down, up and down patterns. More the SpO2 waveform has more this visible up and down movements, that means is fluid deficit. Or suppose the blood loss, there is massive blood loss, even then the waveform will change like this. And there's a third use by the waveform analysis, which is PPWA. This is plethysmographic pulse wave amplitude. 10% decrease in PPWA indicate IV injection of the test dose in epidural with 100% sensitivity, specificity in PPV and NPV, and which is better than the traditional hemodynamic parameters of the test dose that we give in epidural. That was the HR and systolic blood pressure changes. This was all about the uses or the applications of pulse oximeter, and the last topic will be the limitations. Let's talk about it quickly. There are two types of limitations. One is self-limiting, and there are some potentially unsafe limitations. In the safe limitations, they're obviously like the motion artifacts or poor perfusion, skin pigmentation, nail polish, artificial nails, irregular rhythm, electromagnetic interference. These are the safe limitations, because this is not primarily because of the problem with the saturation. Regarding the skin pigmentation, the black, blue and green and some shades of brown, onychomycosis or the dirt, they are going to interfere. But the red, pink, orange and the acrylic nails, they don't interfere with the SpO2 reading. These colors are very important to know, that which colors will interfere and which colors will not. In the irregular rhythm, maybe suppose there is atrial fibrillation, or there is aortic balloon pulsation, which is intra-aortic balloon pump. What happens is, this is aorta, and we insert our intra-aortic balloon pump. This pump, this will inflate and deflate during systole and diastole. So this inflation and deflation of this cuff in the aorta to decrease and increase the systemic vascular resistance. So this will change the pulsatile component, and the reading of the pulse oximeter will vary. You can see this IABP mostly in those LV dysfunction patients in the CTVSOT and is not seen elsewhere. Then there are potentially unsafe limitations. Let's talk about them. There are calibration assumptions, delay in the detection of hypoxia, probe positioning, ambient light interference, abnormal hemoglobin, venous pulsation and intravenous dyes. In the abnormal hemoglobin molecules, like carboxyhemoglobin, methemoglobin, HbS or fetal hemoglobin, you need to see that carboxyhemoglobin, if it increases 1% increase in the carboxyhemoglobin, the pulse oximeter overreads by 1%, because the extinction coefficient is similar to the oxyhemoglobin. That is the reason carboxyhemoglobin, suppose the normal saturation of the patient is 70, but it will show as 90%, and you will feel like the patient doesn't require oxygen supplementation, where actually it does. Regarding the methemoglobin, it absorbs equal amount of red and the near infrared light. That means the ratio of the pulsatile and non-pulsatile absorption at the two wavelengths is equal to 1 at a hemoglobin oxygen saturation of 85%. That means if the patient saturation is actually suppose 40 to 50%, then also it will show 85. If the saturation is 90%, then also it will show 85. So it doesn't matter what the saturation is. If the patient has methemoglobinemia, it will continue to show a saturation of 85 because it absorbs equal amount of red and equal amount of infrared light. This is about the methemoglobin. In the fetal hemoglobin, it is similar to the adult, so it does not interfere with the pulse oximetry. Or HbS, which is the sickle cell. Even that doesn't interfere. In the venous pulsation, suppose there is tricuspid regurgitation. So in the severe tricuspid regurgitation, there will be wrong SpO2 readings. So if you get a patient with tricuspid regurgitation and there is changes in SpO2, you should know that it is because of that TR. Then regarding the IV dyes like isosulfan blue, methylene blue, indocyanine green, they absorb more of 660 nanometer. That means it will show a low saturation, but this is a short-lived effect, and because of the redistribution of the dyes, it will start to show normal values. Bilirubin, increase in bilirubin, that is jaundice, has no effect. Anemia has no effect, except in the sickle cell anemia when there is a vaso-occlusive crisis because of the decreased perfusion. Otherwise, even in HbS is present or the Hb itself is very less, it doesn't have impact on the values. Polycythemia has no effect. A pressure on the sensor, inaccurate SpO2 readings, but the pulse rate is normal, and that is why it is asked that you should not press onto the pulse oximeter. You should not touch the pulse oximeter, you just have to attach it and leave it as such, because this pressure will give inaccurate SpO2 readings. Then hyperemia, when it becomes pulsatile, capillary blood and venous blood becomes pulsatile, it will interfere. And now there are multi-wavelength pulse oximeters. This is a latest advance. In the Massimo Red 57, FDA approved in 2006, it can also tell you how much is the carboxyhemoglobin, how much is the methemoglobin, how much is the sulfhemoglobin. So it can tell you different types of hemoglobin also nowadays. Now we come on to the last segment of this video. We know that carboxyhemoglobin poisoning, it will show a false normal or higher value, and false SpO2 is seen in methemoglobin, sulfhemoglobin, IV dyes and venous pulsations. We have already studied. But there is a difference between sulfhemoglobin and methemoglobin. In methemoglobin, the iron is oxidized to Fe3+, which will increase its affinity. And we know that ultimately, because of the equal absorption, it will show a saturation of 85%. But in this sulfhemoglobin, it along with this component, the sulfur atom there's a sulfur atom in the porphyrin ring, and it absorb more of red light, which will shift the ODC to the right side. So there are fewer adverse clinical effects as compared to the methemoglobin. And for these sulf-meth hemoglobin and deoxyhemoglobin, cyanosis to develop, we need that much of concentration. For sulfhemoglobin 0.5, for methemoglobin 1.5, and 5 gram per deciliter of deoxyhemoglobin should be present to clinically detect cyanosis. That's all about all the components of pulse oximeter, and thank you.